and open the webinar.
Welcome everybody to our cancer conversations. We're going to give about 30 seconds more for folks to join, and then we're going to go ahead and get started. Okay, I see we've hit the 1 minute after mark. Thank you so much for joining us this afternoon for Cancer Conversations, Colorectal Cancer from Prevention to Survivorship, a program that's co-sponsored by the Center for Health Equity and Community Engagement Research, as well as the Cancer Center at Mayo Clinic. My name is Dr. Jewel Kling. I'm an internist and the chair of Women's Health Internal Medicine, and I have the privilege and pleasure of moderating as well as sharing with you this afternoon about some important aspects of colorectal cancer screening. Our layout for the next hour is first, we'll just do some brief introductions as well as introduce you to our excellent other panelists. We'll also do a knowledge assessment survey. And then we're going to start first with a physician perspective or a clinician perspective, where we'll talk about screening and prevention, both from a primary care viewpoint and then insights from a GI specialist. After that, we're very honored to have Amy here, who's going to share her personal experience of navigating colorectal cancer and share insights to inform all of us as we think about our own personal experience and history as it relates to colorectal cancer screening. After that, we'll have the opportunity for an interactive question and answer section. So please, along the way, if you have questions that come up, feel free to enter them into the Q&A box there. We have a couple folks in the back end that are checking for those, and we'll bring those to our attention. And then we'll wrap things up. So with that said, our first task here is to ask a favor of you. Those that are attending, we'd love to get your insight, a baseline knowledge, if you will. So you'll see here that we have a QR code on this slide. For those that haven't used these, if you grab your phone and just go to the camera section, you'll be able to pull up the survey just directly from your phone. It shouldn't take you too long. And I think we'll just pause here for about 30 seconds to allow folks to grab those and to work on completing the survey. I feel like we need some music or something while folks are filling out the survey. Anybody offer to sing while we're doing this? Amy, Dr. Samadder? No? Okay.
I can do the Jeopardy melody.
There you go. It looks like we also put the link to the survey in the chat box. So if you're having some difficulty pulling it up on your phone with the QR code, you can go ahead and click to it from the chat box. Well, I want to be cognizant of time, your time, our speaker's time. So I'll go ahead and start introducing your panel as you're completing that survey, and just an extra thank you again for filling that out. That really helps inform future sessions. So first of all, I'm your first speaker this afternoon. As you heard, my name is Dr. Jewel Kling. I am a internist that has the privilege and honor of providing primary care, mostly to cisgender women, but to some cisgender men as well as transgender people. And so from that perspective, in my day-to-day practice, get the opportunity to talk about colorectal cancer screening and prevention. I also have interest and expertise in menopause, sexual health, and LGBTQ care, and have served as the Associate Chair of Equity, Inclusion, Diversity for our Department of Medicine. I'm going to be talking to you about prevention, colorectal cancer screening, and how to screen, and really tools to think about for prevention. After I share that with you, Dr. Jewel Samadder is going to talk to you from a GI perspective. Dr. Samadder is a consultant in the Division of Gastroenterology and Hepatology in the Department of Medicine here at Mayo Clinic in Arizona. He's also the Associate Program Director for the Gastroenterology and Hepatology Fellowship Program and a Program Leader for Clinomics in the Center for Individualized Medicine in Arizona. His research focuses on genetics of cancer development, opportunities for prevention and targeted or precision cancer therapy, which really makes him perfect for this discussion today. He's going to talk to us in more detail about those different screening tests, as well as more information. And then after you hear from the clinician perspective, we have the honor of having Amy Figs joining us today. She's author of Upgraded to Chronic. She was born in Maryland and spent her youth in Pennsylvania, and then moved to Lexington, Kansas as an angsty teenager. After high school, she started at the University of Texas, but was unceremoniously asked to leave after a few failed semesters. She did return, however, and completed her degree in family sciences in 2013, graduating summa cum laude. After working 11 years in the insurance industry, she changed paths and began a career in case management, first for severely emotionally disabled children, then onto homeless transitional age youth and foster children. You'll hear more about this, but she was diagnosed with stage 4 colorectal cancer on October 1st, 2015. After a year of chemo and fear, she was able to have colon and liver resection done in November 2016 at Mayo Clinic in Jacksonville, Florida. She is no evidence of disease ever since, which is fantastic. Yeah. When she isn't writing, she's outside enjoying nature in some capacity, enjoying time spent with her son and her dear friends, or quietly writing poetry from a coffee shop or her back porch. She dreams of owning a small plot of land one day with a tiny home and a breathtaking view. Excellent. Amy and Dr. Samadder, thank you so much for joining our panel. Well, I'm not sure if everybody's sick of hearing me talk yet, but you get another about 5 or 10 minutes of hearing me talk about the kind of primary care perspective of colorectal cancer screening. And maybe a good place to start is just highlighting why we're talking about colorectal cancer. You know, this is a common and lethal cancer worldwide. In fact, it's one of the leading causes of cancer death in the United States. Why screening is so important is because it saves lives. And when we do it appropriately and at the right time, it can make such a big impact on so many people's lives, not just here in Arizona or in the US, but globally. One thing I'd just like to highlight or clarify now is what I'm talking about is screening for colorectal cancer. And the important point here is to know that that's for people that don't have symptoms. You know, I often hear from my patients, Dr. Kling, I don't want to do a colonoscopy or do some, colon cancer screening. Plus, I'm not having any symptoms. I don't have abdominal pain. I don't have constipation. I'm not noticing blood in my stool. Well, the important thing here is to know that what we're talking about is looking for things before you even develop symptoms. Now, colorectal cancer starts by, or is formed typically by, small polyps that form in your colon. And those polyps can go on to become cancer. The really fantastic thing about our screening tools is that we're able either to directly visualize those polyps and then remove them so they don't go on to become cancer, or find reasons to suggest there might be a polyp, such as doing a stool test, like a FIT test, or a Cologuard test, which you'll likely hear about a little bit more from my next colleague. But these tests tell us that there might be something in the colon, which then prompts us undergoing a colonoscopy to visualize or look for those polyps and then remove them. Some of you may be familiar with the screening age for colonoscopy, or for rather colon cancer screening, because either you've reached those age and you've heard it from your doctor, or you've heard it on the news or in other arenas. But just to make sure we're all on the same page, just recently in the last couple of years, the screening age has gone from 50 down to 45. So any of you that are listening and fall within that age range, if you've not had the opportunity to talk to your healthcare practitioner about screening, now's the time to do it. For folks that are average risk, meaning you don't have things like a family history of colon cancer, or you've never had a polyp found on a colonoscopy in the past, the options for your screening are a little bit broader than those that have an elevated risk or a history of polyps. It would include either colonoscopy, which is a scope that goes through your colon and looks for those polyps. That's done every 10 years if you don't have any polyps, starting at age 45. There's a FIT test, which is a fecal immunochemical test, which basically you take it home, and after you have a bowel movement, you'll collect some sample and send it in. For those of you that are interested in finding out more and potentially enrolling in a study with a FIT test at Mayo Clinic, we'll be sharing a phone number where you can call and enroll in that study that we're offering through Mayo. There's other stool tests, something called the Cologuard, which looks at DNA of the polyps in the stool. But similar to the FIT, you take it home, you collect a sample, and then you send it in. Now, each of these tests have a different frequency for follow-up. So some of you thinking, great, I do a colonoscopy and I never have to worry about it again. That's not the reality. It's something that you'll need to do again in the future. As I alluded to, the colonoscopies every 10 years, unless you have polyps found, and then you might hear from your doctor, hey, you need to do this every 3 years or 5 or 7, depending on what they see. The FIT test is annual, then the Cologuard is every 3 years. I mentioned that prevention is important, and it certainly is. I think the good news here for y'all, waiting to find out what the key to preventing colorectal cancer is that it's similar to what we share with folks for other cancers. Living a healthy lifestyle, making sure that you're moving regularly is important. Making sure that you're eating a healthy, balanced diet, lots of fruits and vegetables, minimizing processed foods, perhaps minimizing red meats, especially processed red meats. Alcohol is something to be mindful of, either minimizing or avoiding alcohol. And then tobacco. So if you smoke, working with yourself and your medical team to figure out a path so that you're not smoking can be helpful. And then if you don't smoke, don't start. Before I hand it over to Dr. Samadder, I want to just mention a couple of important factors related to social factors and health equity. I mentioned that colorectal cancer is a common cancer and leads to a significant amount of mortality. Well, unfortunately, we see incident rates and mortality for colorectal cancer higher among certain groups of people, including Native American, Alaskan Native, Native Hawaiian, other Pacific Islanders, and Black people, particularly Black males. Also, we see incidents disproportionately higher in certain geographic locations, such as the Mississippi Delta region, that's correlated with things like socioeconomic disadvantage. And so I'm so grateful that all of you are here so that you can get this information, because some of it's about information, but some of it is about societal barriers. mistrust with healthcare, lack of access to care, historical social injustices that have created barriers to folks getting adequate colorectal cancer screening. At Mayo, our goal is to help bring down those barriers so that there's equitable access to colorectal cancer screening. But we wanted to make sure that you were aware of this information and the work that we're doing in this space too. So with that, I'm going to wrap up here and just remind you again to talk to your healthcare practitioner about screening for colorectal cancer, also talking about your risk level and if you're average risk, considering some of those studies that we talked about, looking at those tools to help you prevent colorectal cancer as well as live a healthy life, and then being cognizant of those social factors and disparities that exist. With that, I will hand over the virtual stage to my colleague, Dr. Samadder.
Thank you so much, Dr. Kling, for that wonderful encapsulation of colorectal cancer screening and prevention options. If it's okay, I'm going to share my screen with everyone and then launch my presentation here. Can everyone see the presentation view, or is it on the presenter view?
You're in
It's on the presenter view.
Okay.
John.
How about now?
That looks great.
Perfect. Well, thank you again for that introduction of me, as well as the opportunity for me to participate in today's conversation. So as you heard, I'm a gastroenterologist. So part of my job every day is to do one of the tests that are associated with colorectal cancer screening, colonoscopy. But I want to take really the next 10 minutes and give you a broad overview of the epidemiology of colorectal cancer in the United States, what are happening with what groups are at risk, is there a decline, some of the evidence around cancer screening, and other risk factors that we don't often think about, including genetic risk factors. How do we elucidate if you are genetically predisposed to develop colorectal cancer? And then finally, I'll talk a little bit about the future of early detection and interception of cancer broadly. So colorectal cancer, as you heard from Dr. Kling, is one of the most common causes of cancer-related mortality in the United States, or death from cancer. There are approximately 150,000 new cases of colorectal cancer every year in the US, and this results in 50,000 Americans losing their life to this disease. The lifetime risk we talk about is 6%. That means 1 in 17 persons will develop colorectal cancer. What you see in this graphic here is in purple, the purple solid line at the top, that is the colorectal cancer incidence. So how many people are getting colorectal cancer year after year? And you can see over time since the 1980s, the mid-80s, it has been coming down, and that's excellent. Many people believe that at least part of that decline is due to colorectal cancer screening. And in green solid, so this green line that I'm following here, represents the uptake of colorectal cancer screening. That's stool-based testing and endoscopy, and then later on other tests that have come out, including blood-based testing to a lesser extent and imaging. And as screening has increased over time since the 80s, 90s, and into 2000s, you can see CRC incidence and death or mortality from CRC has come down. Is even people who have been found to have colorectal cancer with a screening test are usually identified at an earlier stage when they are asymptomatic and where cure rates are much higher. So what is the evidence for colorectal cancer screening? So I'm going to only very briefly talk about this in a few slides, but you can see we can divide colorectal cancer screening into two types of tests. Those that are based on a stool test, so a small sample of stool is collected at home or at the doctor's or nurse's office and then sent for analysis. That can be what's called a guaiac FOBT, which is looking for microscopic blood in the stool sample. A FIT test, or fecal immunological test, which is basically also looking for human blood in the stool sample, but with an immune assay. And then probably one of the newer tests on the market called multi-target stool DNA, or by the brand name Cologuard. This is looking at a stool sample for a number of genetic or DNA markers that are associated with colorectal cancer. And what this tells us is the sensitivity of the test. This is, if I did the test one time on you, how likely would a negative test rule out the possibility that you have colon cancer? And you can see the older FOB tests are really not very good. It's about 50% sensitivity. That means it's a flip of the coin, basically. However, as we go to FIT and then to stool DNA, you're getting into 80 to 90% sensitivity to rule out colorectal cancer. But the ability of these stool tests to detect or rule out precancerous lesions is much more limited, well below 50%. And that is one of the limitations of the stool test, is that though they may be adequate for detecting or ruling out colon cancer, they are not adequate for identifying or ruling out if you have precancerous colon polyps that can later develop into colon cancer. The other set of tests we talk about are called structural colon tests. And these are things like CT colonography. You'll often hear this referred to as virtual colonoscopy. This is using a CT scan to scan your colon, create a three-dimensional model of it, and identify if there are cancers or polyps in it. And then sigmoidoscopy and colonoscopy. Colonoscopy is where a telescope is inserted into the bowel while you are sedated after you've completed a bowel preparation to flush the stool and other matter out. So this telescope is inserted in, goes throughout the colon, which is about 3 to 3.5 feet in length, and removes any colon polyps or precancerous lesions that exist there, with the hope that we can prevent you from developing colon cancer ever. And you can see we look at colonoscopy as the gold standard test that we compare everything to. It has the ability to rule out that you have colon cancer over 95%, and the ability to rule out if you have polyps or advanced large colon polyps 90 to 98%. So this really is the gold standard test, and every other test, whether stool or imaging, is compared to it currently. The evidence for colonoscopy really dates back the last 20 years, and there are several studies now done in the United States, Canada, Australia, and Europe, all of which show the same thing, that getting a colonoscopy is protective from developing colon cancer. So without going into numbers, whenever you look at numbers like this, what we call odds ratios, if they are below 1, it means they are protective or reduce your risk of developing cancer. Is colorectal cancer screening cost effective? Absolutely. What you can see in this slide here is, if we were to look at all different types of technologies that exist as to what is the cost of using that technology for the year of life saved, if we were to put it into a financial metric, you can see one of the most cost-effective things is actually having a mandatory motorcycle helmet, because it saves the likelihood of you having significant brain damage or death from an accident. Breast cancer screening at $35,000 for a year of life saved. Dual airbags in our cars. All of our cars now have driver and passenger airbags, but it costs $120,000 for that year of life saved. Smoke detectors, school bus seat belts. But you can see here, colorectal cancer screening is very cost effective at $25,000 spent by society for every year of life saved. And we have generally, in cost effectiveness studies, said that anything that is really under $100,000 of cost for quality adjusted life year saved is worth it. In older studies, it was 50,000, but now we're really approaching 100,000. So colon cancer screening, highly cost effective. How do we improve colon cancer screening? So if you were to look this up on Google, you would see all these different technologies that are coming around. Things like chromoendoscopy, where we can spray your colon with a blue dye and it can highlight polyps that would otherwise be hidden without that blue dye. So you can see in the picture where I'm circling, under white light without the blue dye, you can barely see this colon polyp, But after the blue chromo endoscopy dye, it's much more apparent where that precancerous polyp is. We can design new scopes that have cameras on the side of the scope instead of just on the front, so that we get a 270-degree view of the colon. We can use artificial intelligence. So this is a product that can be added to colonoscopy, which can use little green boxes here to identify polyps to help the endoscopist ensure they're removing all of the polyps they're seeing on the screen. But for all of those technologies that I've talked about, the most important impediment to colon cancer screening is patient behavior and insurance coverage. So what this slide shows us is that even amongst all adults in the United States, any kind of colon cancer screening is underutilized at only 52% of the population. That number in those above 65 who are insured goes up to 60%. And if you are not insured, obviously it is very low at less than 25%. So I would say for all of the technologies I'm mentioning, the most important thing we can do, Dr. Kling and myself today, is encourage you to have a discussion with your family doctor or your primary care doctor about, do you need colon cancer screening, and what test for colon cancer screening is appropriate for you. Any test is better than no test. But going back to colorectal cancer epidemiology for a second, there are storm clouds on the horizon. Even though I showed you that data on that slide that overall, as screening has increased, colon cancer incidence and death has decreased, that is not true in all populations. This is a complicated graphic here, but really, if you concentrate on just the top row here, this is looking at colorectal cancer incidence by age group. And what I'm going to point out to you is in those below age 50, we are seeing an increase in the risk of developing colorectal cancer over the last 20 years. That is most pronounced in young females developing rectal cancer. Why? We don't know. It may be a combination of hormone use, oral contraceptives, antibiotic use, pesticides in our food, obesity. These are just other risk factors that seem to have paralleled the increase that I'm showing you over time. But this is just to show you that one of the reasons we decreased the age of colorectal cancer screening from 50 to 45 was because of this national trend in increase in colon cancer in young people. I'm going to shift gears to the second part of my conversation now, which is other risk factors we should be aware about for colorectal cancer. The most important of which is genetic or hereditary causes. So this is how physicians often will present a family history, or what we call a pedigree. We will draw, starting with the index person sitting in our clinic, who they're related to, their sibling, their parents, and going up generation after generation, drawing out their uncles, their aunts, their cousins. And then this graphic, this is a real family of mine, where all of the people in black are those with colon cancer in this family. And it really highlights that colon cancer is one of the most genetic or familial cancers, where it can be inherited in multiple generations of a family. And it looks like every generation here, half of the people were affected by colon cancer. So you might ask, why in this generation are there so few colon cancers? It's because this is when colonoscopy was introduced broadly, and patients in this family started doing colon cancer screening. And you can see it nearly prevented every case of colon cancer in this family except one. So when we look at hereditary or genetic causes, we can think about any cancer, whether it's breast, ovarian, colorectal, pancreas, is that in 70% of cases, we don't have a clear genetic basis. In another 20% in this darker blue here, or purple, there's a strong family history of that same cancer, but there isn't a clear gene. And in about 15 to 20% of people with breast, ovarian, colon, pancreas, or prostate cancers, there's a clear genetic element. There's one gene that is floating down throughout the family, and we can often identify that genetic cause and then appropriately screen members of the extended family with that genetic predisposition for whatever cancer they're at risk of, hopefully preventing or catching early cancer in that family. So why is understanding genetic risk important? Well, for a family like I showed you in that family pedigree there, it can help establish a diagnosis of why there are so many cancers in the family. It can provide for targeted prevention in the family members with a genetic risk factor. And in people who develop that cancer, often we can prescribe precision or targeted chemo or immunotherapies that work better because that particular cancer is at a genetic level targetable. We'll skip that slide. Genetic testing nowadays is not offered where we do 1, 2, or 3 genes at a time, but we can test you for 100 cancer genes at the same time. So when I see patients in my genetics clinic, I test them for all of the genes, not just for colon cancer and colon polyps, but for breast, ovarian, prostate, pancreas, and lung cancer all at the same time. At Mayo, we've really led in this area. We had a program that really cemented genetics as important in cancer care. This was called the Intercept program, and we offered genetic testing to over 3,000 cancer patients across our 3 campuses at no cost. Got rid of all of the barriers with genetic counseling that often occur for genetic testing through pre-test video testing. We offered no-cost testing to any family member of a positive genetic patient as well. And we found that about 15% of cancer patients carried a genetic cause of cancer. About half of those would have been missed had we used standard practice guidelines to decide who should or shouldn't have genetic testing. And in about a third of the cases, we actually changed the treatment, either the chemotherapy, the immunotherapy, the surgery, or even the enrollment in a precision targeted clinical trial for the cancer patient because of that genetic testing we did. Genetic testing is the other thing I want people, anyone on this call or on this webinar who might have colon cancer or has a family member with cancer, talk to your oncologist and say, I want genetic testing. That is the future of targeted prevention and targeted therapy. And we know that genetics is underutilized in cancer programs outside of the big cancer centers like Mayo Clinic. So that's a take-home point. If you have a loved one with cancer, tell them they need to ask their oncologist, what genetic testing should I get done? I'll skip this. And why do I have a picture of Angelina Jolie here? Because Angelina really is the face of genomics and cancer. So she was affected by this in her family. Her mother had ovarian cancer, which led to her mom and then her getting genetic testing and identifying that she carried a gene mutation called BRCA, which predisposes you to developing breast and ovarian cancer. She really shared her story on the cover of Time magazine in 2013, and this opened up that discussion in the public about the importance of genetics in preventing cancer and allowing us to target precision therapy for cancer. She was also a major advocate for what's called GINA, the Genetic Information Non-Discrimination Act that was signed during the Bush administration. This act is a federal law or act that states that health insurers cannot look at genetic testing information. They cannot ask you about genetic testing information. They cannot use it to preclude you from purchasing health insurance or changing your premium for health insurance. So health insurance is federally protected by this act from any genetic discrimination. However, genetics and any new technology brings up the aura of, can this lead to disparities in care? We know there are disparities for race and ancestry in terms of cancer screening, access to clinical trials, and cancer survival. We need to work doubly hard to make sure that genomic medicine does not result in that same disparity in care. The last 2 things I'm going to talk about. One of the major programs that we have at Mayo Clinic is the Tapestry program. This is a program where on a single sample of saliva, we are testing 100,000 people, 100,000 patients at Mayo Clinic for a number of cancer and cardiac predisposition genes called Lynch syndrome, BRCA1 and 2, and familial hypercholesterolemia. That genetic information is then integrated into your electronic health record and follows you throughout your lifetime of care at Mayo Clinic. We have now enrolled just over 81,000 patients at Mayo Clinic, and we expect to complete enrollment of the last 20,000 patients by the end of this year. This was a study just published in the Annals of Internal Medicine, which showed that what we're doing at Mayo Clinic with clinic-wide or population-wide exome sequencing is actually highly cost-effective if applied in the US population. And this article really showed that patients between 30 and 40 years of age, not selected for any family history, any race, ethnicity, could be offered exome sequencing for those 3 genetic conditions I talked about, and it would save a life year at a cost of less than $100,000. So going back to that cost effectiveness. So really, this is going to become a norm for all of us, that genomics is going to be integrated into our care paradigm. The last thing, and I couldn't stop myself from sharing this, this is, I think, the future of cancer prevention. We call this multi-cancer early detection, or MCED. This is, we feel, the holy grail of medicine. It is going to be utilizing a single blood sample, and we can look in that blood sample for circulating fragments of DNA for not just one cancer, but 20 to 50 cancers. And we can hopefully detect that cancer before it is ever clinically symptomatic for you, especially for a variety of cancers like ovarian cancer, lung, and pancreas cancer that are very deep in your body, don't have great screening options. This may be the future of how we screen for cancer. So I'll stop there and I'll stop sharing, and I know we're going to take questions at the end. So I'm going to transition over to Miss Amy Figs to share her story with us now.
Well, Dr. Samadder, before we transition to Amy, first of all, that is an excellent presentation and such exciting kind of on the horizon information for all of us. There is a question that's relevant to your discussion I thought we could just address before we hand it over to Amy. One of the attendees asked, my father had a different GI cancer, esophagus and stomach. Does that affect my likelihood of developing colon cancer?
It doesn't affect your likelihood of developing colon cancer unless there was a genetic syndrome that predisposed your father. That being said, we know people who have gotten esophageal or gastric, so esophageal or stomach cancers, their family members are at higher risk of developing that cancer. There are shared risk factors. So the most common risk factors for those 2 cancers is either reflux of acid into the esophagus, which can burn the esophagus lining, causing a Barrett's, which is the pre-cancer form of esophageal cancer, or for the stomach, getting an infection called H. pylori, which was more common in the United States in the 60s and 70s, but can be transmitted within households. So I would say, from your point of view, you should go to your family doctor and have 2 questions. One is, my dad had esophageal and stomach cancer. Do I have any symptoms that would put me at risk of those? Should I do any screening for esophageal and gastric cancer? And number 2, if I'm above 45, should I get colon cancer screening at this time?
Excellent. Thank you so much for that response. And maybe that's a good transition to Miss Amy Figs. Thank you so much for joining us, and we look forward to hearing your story. Would love to hear how your interaction is part of that, with your clinician and about your diagnosis. So the floor is yours. Thank you so much.
Sure. Thanks for having me. Yeah, I'm going to share my personal story, so I don't have a lot of statistics or percentages to back it up. But so I am a survivor of stage 4B colorectal cancer. I had cancer in my sigmoid colon that metastasized to my liver. I'm in Kentucky. I'm Lexington, Kentucky. The day after my 45th birthday, I had stomach cramps and went to the urgent treatment center to, see if I could get some relief and possibly some Phenergan. And the doctor saw something kind of off about my fever and the cramps and just the way things were presented, and sent me for an immediate CT scan. And with that, they saw liver lesions on my CT. So he sent me immediately to the ER. which I had never had happened to me before, and I was scared to death. And I spent a long 8 hours in the ER waiting for a bed and waiting to get seen. And at that time, they admitted me because of the liver lesions and assumed that I had an infectious disease and started pumping me full of antibiotics and trying to get rid of this infection. And through that, they, as they couldn't determine what it was, they took me for a liver biopsy. And that's when they found adenocarcinoma cells, which are colon cancer cells in my liver. So that was October 1st, 2015 is when they gave me that diagnosis. That day or that night, I had to do a colonoscopy or prep for a colonoscopy where they determined that the cancer had originated in my sigmoid colon. So, when you're diagnosed with cancer, that's all you hear. You don't hear any of the treatment options. All you hear is cancer. And I had no idea what was happening to me. I was scared I was going to die. And so as my sweet oncologist tried to tell me exactly how we were going to treat it and kept saying, it's treatable, never said it's survivable, but he said it was treatable. I didn't hear any of that. They gave me a port in the hospital and started me on chemotherapy right away to make sure I could handle it while I was still in the hospital. And I was in the hospital for about 10 days. Once I was discharged, I went home with a port and orders to go back in 2 weeks and get another round of chemo. And I was told that I was just going to do a year of chemo and see what happened. I wasn't given much of a plan beyond that. I'm here in Lexington, Kentucky. I went to the Baptist hospital here. And I don't think that, every oncologist knows everything about every cancer. So I wasn't told I was surgical. The only option was first round chemo, which is called, I think, FOLFOX. And I responded well to that. I did. And so eventually, after several rounds of chemo and starting to do research and kind of come to my senses, I started to question why they weren't doing surgery and cutting it out, because that to me seemed like the best option was just to remove it from my body. And there were so many spots on my liver that my oncologist told me he didn't think it was surgical, that they would have to essentially melanvol my liver to get rid of it. And that wasn't sustainable. So I kept doing chemo and kept kind of questioning what my future looked like as somebody who had stage 4B cancer and what was going to happen to me. And the best response that I got was I was going to be on chemotherapy for the rest of my life, where I would take, I would do high doses, early on, and then eventually maintenance doses. And, with kids and a life and a job, it just didn't seem sustainable to me. It didn't seem like a quality of life I wanted. So my family, my father and mother had lived in Jacksonville for a time, and my dad had some surgical stuff taken care of at Mayo Clinic. And he said, I have to go down for some follow-ups. Why don't you get a second opinion at Mayo Clinic? And so I did. I was kind of overwhelmed by the thought of calling for a second opinion and trying to navigate that. But I called and one person took my name and took my information and arranged for everything. It was seamless and easy. And I'm not doing an ad for Mayo Clinic, but it made it very easy for me. And I was lined up with an oncologist and a colorectal surgeon with Mayo in Jacksonville. And I went down there. Dr. Murcia gave me an exam and said he thought that I was 45. And at that time, screening didn't start till 50. He said he thought I was surgical and I was young and had kids and they wanted to be aggressive. So he consulted with Dr. Burns, also there at Mayo, and he's the liver surgeon there. And after some exams and discussions and tumor boards and all kinds of, questions, they determined me a surgical candidate. So we arranged for my surgery. It was in November of 2016, and they resected my colon, they ablated and resected my liver, and I have been no evidence of disease since. I did some follow-up chemo here in Lexington to kind of make sure it's swept clean of any additional cancer cells, but I've been no evidence of disease ever since. So, from my story, I would hope that people understand that no decision has to be final. Keep asking questions, keep pushing. I didn't want to die from cancer. I don't want to die from cancer. So I was lucky enough to have the resources, the ability to go to the clinic and have surgery. It's life-saving surgery. I don't think I would have made it without that. Chemo for life just doesn't sound appealing to me. So I don't have family history. We have, I think my great grandmother may have had some bowel issues, but was never diagnosed. I'm an outlier as far as cancer goes. I had gastrointestinal issues most of my life, but never really questioned what that was because my dad had gastrointestinal issues. So I just assumed I had a weak stomach. I had rectal bleeding probably about a year prior to my diagnosis and was told it was hemorrhoids. I had a hard time passing stool kind of towards the last several months before I was diagnosed. You know, I'm the queen of colonoscopies now. I have them now every 3 years, but I've had probably about 10 in my lifetime now, and I can tell you they are not a big deal. But you know, if anything from my story, just please get second opinions, ask a lot of questions, and survive.
Wow, Amy, what a story. And I'm so happy you got that a second opinion and that you're here to share your story. I mean, I think you remind us all about the power of listening to our bodies and sharing that with our clinician, and recognizing when something is off, and just the journey. So thank you for sharing and for your strength.
Thanks for having me.
We have a couple of questions. I think these are holdover from our earlier presentations. Those that are joining, if you have questions for Amy, please feel free, to put them in the Q&A. One of the questions, I think, Dr. Samadder, you're going to be best to answer this, says, "That's amazing. Any other medical facilities prepared to provide this amazing advanced technology, or is it just provided at Mayo Clinic? Perhaps certain insurances may not allow us to go to Mayo Clinic." Can you talk to that a little bit?
Absolutely, and thank you for that question. And let me first say, Amy, that is such a powerful story. I'm so happy that you saw Dr. Murcia and the team at Jacksonville. I know them well, and I think it really shows that you need to be your own advocate. Reach out, and this isn't an ad for Mayo at all, but reach out to other big cancer centers that are around the country in your state and get a second opinion to see what should be done. And there are specialists who at each of these cancer centers who do just GI cancers or just colon cancer. And to your point, you kind of read into that, and you could see that you can only be good at so many things, right? And whether you treat all cancers or you treat colon cancer, you're going to know more about one of them. And so, to answer the question of the person on the webinar, it depends which technology we're talking about. If we're talking about more genetic testing of the patient and the tumor, that's fairly broadly available now in most major cancer centers. Genetic counseling is more routinely available now at larger hospitals, I would say. There are opportunities where you can meet with genetic counselors through televideo if you're in more rural areas. In Arizona, our Mayo Clinic Hospital here has a partnership with Valley Wise, which is the county hospital, and in urban Phoenix, as well as Phoenix Indian Medical Center, where we do the genetic testing, genetic counseling of those patients. So that's the genetics component. If it's more of the future aspects where I showed with what we call exome sequencing in large populations or multi-cancer early detection, those are technologies that are really on the horizon and are probably at this time only available at those top tier cancer centers across the US. They will slowly come broadly available. That study, Tapestry, which is still running, is available for any Mayo Clinic patient to participate in, but you do have to be a Mayo Clinic participant, or sorry, Mayo Clinic patient. There are similar studies running at a few other centers across the US, but to this point, it's still those two latter technologies are limited to really, large academic cancer centers.
Thank you for that. We have a question here for you, Amy, from a fellow Amy that's attending, asking about how your diagnosis has impacted screening for your family members. If you'd be comfortable, would you share how that's impacted, and maybe even taking that one step further, any opportunities for like genetic testing or things for yourself?
Yeah, so I did genetic testing pretty early on, and I don't have any of the genetic markers. So that, didn't help my treatment much, but I was lucky to be responding to the mainline chemo. And as far as my family, they consider us now to all have history. So my brother, who's about 4 years younger than me, went and got a colonoscopy immediately after I was diagnosed. My dad has had a lot of colonoscopies. He's had a lot of polyps, but never cancerous ones. And yeah, and any of I only have one biological brother, but any of my secondary family, any of my extended family, all just went and got colonoscopies. And my friends all went and got colonoscopies. There was I think the colonoscopy industry in 2015 was probably booming in Lexington, Kentucky. But I encourage everybody and all of my friends, that have any kind of remote family history to go get screened. I was 45 when diagnosed. They think that I had it for about 10 years prior. And so they say 10 years, your offspring should have it, I think 10 years before you were diagnosed. So they said my son, who is now 16, should have it when he's 35. He should be screened. I am a little bit more adamant about him being screened sooner, so we'll pay full price for a colonoscopy for him to be screened sooner, because I prefer him never to have to go through that. But yeah. So anybody that's related or connected to me has had a colonoscopy, and I encourage it, and I am everybody's chauffeur to the colonoscopy.
Excellent. Thank you for sharing. Dr. Samadder, do you have anything else to add as it relates to affected family members and how that influences colorectal cancer screening?
So having any family member that's a first-degree relative increases your risk of developing colon cancer. And we usually advocate that if you have a family member who developed colon cancer at below age 60, you should start colonoscopy at age 40 or 10 years earlier than the youngest colon cancer diagnosis in the family. If there are multiple second degree relatives, so first degree is going to be your mom, your dad, siblings, and children. Second degree will be one generation separate to that. So uncles, aunts, grandparents would be the typical ones for second degree relatives. Having multiple second degree relatives is another genetic risk factor and would also prompt you to get an earlier colonoscopy. If there's a family history of colon cancer, we usually would recommend colonoscopy only. We wouldn't recommend any of the stool-based tests that we talked about because they're a little bit inferior for screening compared to colonoscopy. And once we've decided you're at higher risk than the average population, we put you into the bucket where colonoscopy is preferred.
And correct me if I'm wrong, that's the same for if your first degree relatives have had polyps, not even just cancer. So if your mom or dad had a bunch of polyps, would that impact your screening recommendations?
It's a bit more tricky. The polyps have to be what we call advanced polyps. So these are polyps that are either at the histology pathology level are more advanced or are larger, greater than 10 millimeters or 1 centimeter in size. So if you have colon cancer in a family member at a young age, or what we call advanced polyps at a young age.
Thank you. Thank you for sharing that. And I know that gets a little tricky with all the pathology, but for those listening, just keep that on your radar when you're talking to your folks or to your family members, how that influences your risk. It may just be making sure you're sharing that with your, doctor or advanced practitioner so that they can factor that into the timing of when you should start your screening. I know we're getting close to the end here. There's one additional question that I'll look to you, Dr. Samadder. Again, it has to do with prostate cancer and how that factors into this risk. Like if you had a family member who had prostate cancer, would that increase your risk of other affected cancers?
That's a great question. For a long time, we were all taught in medical school, nursing school, that prostate cancer is just something inevitably that happens to all males. So if males get older, they all get prostate cancer. And that has shifted. Prostate cancer is highly genetic, just like breast, colon, ovarian cancer. And it turns out the same genes that drive the risk of breast and ovarian cancer drive the risk of prostate cancer in males, called the BRCA1 and 2 genes. And so now we recommend that a male with prostate cancer at a young age, metastatic prostate cancer, or aggressive types of prostate cancer should undergo genetic testing, because that genetic testing not only will help that person, that male, kind of with targeted treatments for prostate cancer, but could tell us if their sons are at higher risk of developing prostate cancer, and importantly, if their daughters or sisters are at higher risk of developing breast and ovarian cancer, because the same genes are implicated in all three cancers.
Excellent. Well,
If-
we are at, go ahead. Did you want to add something additional?
I was just going to add, if there are more questions, I know family history and genetics is something that people have a lot of questions about. Please feel free to reach out to genetic counseling programs that we have at each of our 3 Mayo Clinic sites, or you can even Google genetic counselor in your area, and it should give you a list on Google of genetic counselors at area hospitals.
No, that's very helpful, because some of these questions and answers are so nuanced based on family histories that really it has to be individualized. There's a couple of other comments and questions here that we won't have time to address, but please know that we're going to be sharing the recording as well as some other information after this session today. Thank you, all of you, for joining. I see somebody has joined from San Carlos in the reservation and is trying to learn and educate your community members. Joyce, thank you. You're helping us close those disparities we mentioned earlier. In an effort to make sure that the information we're putting together and delivering to you and to your friends and community members is beneficial, we're hoping you will help us by answering our post-event survey. So similar to what we did here at the beginning, if you can grab your phones and do the camera here. We're going to also put the link to the survey in the webinar chat. While we're allowing folks to fill out the survey, Dr. Samadder, Amy, any other kind of final words of wisdom or things you'd love for people just to walk away from this session with?
Hadn't really thought of that, but again, second opinions, ask a lot of questions. Never settle for what you don't want. If you want to live, then fight to live. And that is with cancer and anything, honestly.
I feel like it's almost pun intended, like trust your gut, right? Like listen to that and keep asking those questions. Excellent. To our organizing team, Farhia, Italy, anything else that we wanted to share with our attendees?
We will be sharing the recording, and we'll also share the FitDom study links and flyer and any resources,
as well as the link to the book written by Miss Amy Figs.
Thank you, everyone, for organizing and participating.
Thank you for your insight and expertise. Thank you, Amy. Thank you, everybody, for joining us. We hope this has been informative and you'll get out there and recommend to your family members and beyond to ask about colorectal cancer screening.